Dive. Today we're tackling something super common, but actually quite intricate. Pneumonia.
That's right. We've got a stack of clinical sources here, really foundational stuff.
We're going to map out the definitions, how doctors diagnose it, and importantly, how they decide on treatment, especially for community-acquired pneumonia.
Yep. Our goal is to give you that clinical roadmap fast.
Yeah.
From the basic definition, how it spreads, diagnostics, all the way to specific treatment groups for CAP.
Okay, let's unpack this.
Let's do it.
So the definition first. It sounds simple, but in medicine it's very specific, right? Not just any cough or cold.
Absolutely not. To be called pneumonia, you need two key things. First, an infection of the lung tissue itself, the parenchyma.
Caused by what? Bacteria? Viruses?
Could be bacteria, viruses, or even fungi. That's the infection part. But crucially, the second part is you must see consolidation on an X-ray or a similar scan.
Consolidation meaning?
Meaning the lung tissue looks dense, solidified with fluid and inflammatory cells. It's not spongy like it should be.
Ah, okay, so that X-ray confirmation is essential.
It is. And that brings up a really important distinction the sources highlight. Pneumonia versus pneumonitis.
Right. That one letter makes a huge difference.
Massive. Pneumonitis is lung inflammation, sure, but not from an infection. Think chemical fumes, radiation therapy side effects.
So no bug involved.
Exactly. Inflammation plus infection equals pneumonia. Just inflammation from something else. That's pneumonitis. And you treat them completely differently.
Makes sense. Okay, so we know what it is. How do these infectious agents actually get into the lungs? The sources list 4 main ways.
Yeah, 4 pathways for infection spread. The first one's obvious. Inhalation. Just breathing in droplets, carrying the bugs.
Standard stuff.
Then there's aspiration. Breathing in small amounts of stuff from your own mouth or throat. Oropharyngeal secretions.
Like accidentally? While sleeping, maybe?
Exactly. Happens to everyone. Usually your lungs clear it. But if defenses are down, or there's a lot of bacteria, it can set up an infection. This is probably the most common route, actually.
Interesting. What are the other 2? They sound more serious.
They generally are. Hematogenic spread means the infection travels through your bloodstream from somewhere else in the body.
Like a skin infection getting into the blood and landing in the lungs.
Precisely. Or an infected heart valve. And the last one is direct spread. Infection moving directly from a structure right next to the lung, like the chest wall or the space between the lungs, the mediastinum.
Wow. So lots of potential entry points if the conditions are right. What makes the lungs vulnerable then? What are these predisposing factors?
It's mostly about weakening the lungs' defenses. Damage to the airways, mechanical barriers, the little hairs, the mucus lining.
With the cleaning crew.
Exactly. If that's damaged, bugs get in easier. Also, any injury to your immune system, specific or general.
Makes sense.
Then there's bronchial obstruction. If an airway is blocked, mucus and bacteria get trapped behind it. Perfect breeding ground.
Drainage is key.
Absolutely. And finally, things like recent viral infections often pave the way for bacteria. Or having extra fluid in the lungs already, lung edema, it just makes the tissue more hospitable to invaders.
So compromised defenses, blockage, existing inflammation sets the stage. If an infection does take hold, what are the big symptoms someone would feel? The ones that make you think, oh, this isn't just a cold.
The classic symptoms are usually pretty dramatic. Think sudden high fever, often with really intense shaking chills.
Like teeth chattering chills.
Yes, exactly.
Yeah.
A bad cough is typical, usually producing sputum, so coughing stuff up. And often sharp pleuritic pain, chest pain that gets worse when you take a deep breath or cough.
Ouch. Any others?
Yeah, people usually feel generally unwell. Difficulty breathing, what we call dyspnea, extreme fatigue, sweating, no appetite. Just feeling really sick.
Okay. And when a doctor examines someone with those symptoms, what specific physical signs are they looking and listening for? The clues that point to that consolidation we talked about.
Right. This is where the physical exam is crucial. They might feel for increased vibration on the chest wall over the affected area. Increased thoracic vibration.
Feeling the vibration through their hands.
Yep. Then they'll tap on the chest. Percussion. A healthy lung sounds sort of hollow.
Like a drum?
Kind of. But over pneumonia consolidation, it sounds dull, dense. We call that impaired percussion or matity, like tapping on wood instead of a drum.
That's a great way to put it. What about listening with the stethoscope?
That's often where you get the clearest signs. You might hear end inspiratory rails or crepitations.
What do those sound like?
It's often described like Velcro tearing or crinkling cellophane. Little crackling sounds at the end of a breath in. It means small airways are popping open.
Okay.
And the other big one is bronchial breathing, sometimes called tuber souffle. Normally you hear soft, rustling breath sounds. With consolidation, the sound transmits much more clearly, almost like listening directly over the windpipe. It's a harsher, louder sound.
So those physical signs really help confirm the suspicion. But moving to diagnosis,
Hmm.
the sources are really clear. The chest X-ray is the key.
Absolutely. Lab tests like sputum cultures, serology, blood counts, they're all important pieces of the puzzle. But the chest X-ray is called the gold standard test for pneumonia.
Why gold standard? What makes it so vital?
It does several critical jobs. One, it confirms the diagnosis, you see the
It's
consolidation.
visual proof.
Exactly. Two, it helps with differential diagnosis, ruling out other things that might look similar, like heart failure fluid or a lung mass.
Okay.
Three, you can use it to help grade the severity. Is it just one small patch or a whole lobe? And four, you look for complications, things like a lung abscess, which is a pocket of pus, or fluid around the lung, pleurisy.
So it's doing a lot more than just saying yes or no to pneumonia.
Definitely. It gives you anatomical information, severity, potential complications. It's huge.
And when they look at that X-ray image, what kinds of patterns are they seeing?
They look for different types of opacities or white areas, which show where the lung is dense. You might see lobar opacities, where a whole lobe is white,
Clear boundaries?
usually. Or you might see interstitial images, which look more like fine lines or haziness spread through the lung tissue, not confined to one lobe.
More diffuse.
Right. And the third type is bronchopneumonic or patchy opacities. These are scattered, fluffy patches, often centered around the airways.
Okay, so the pattern tells you something about how the lung is involved.
It can give clues, yes.
Yeah.
And that leads us nicely into how pneumonia is classified.
Right. There are different ways to categorize it.
Several ways. Anatomically, based on those X-ray patterns we just discussed, lobar, bronchopneumonia, interstitial, by cause or etiology, bacterial, viral, fungal.
Uh-huh.
But probably the most clinically useful classification, especially for starting treatment, is based on where the patient likely got the infection and their immune status.
That's where CAP comes in.
Exactly. We divide it into community-acquired pneumonia, CAP, picked up outside a healthcare setting, often in relatively healthy people, then hospital-acquired pneumonia, HAP, or nosocomial, and pneumonia in immunosuppressed patients. Each has different likely bugs and needs different approaches.
And we're focusing today on CAP, the community kind. But even within CAP, there's a really critical split doctors make almost immediately, right?
Yes, this is maybe the most important initial assessment, distinguishing between typical pneumonia and atypical pneumonia.
And this is based purely on how the patient presents, before lab tests confirm the specific bug.
Largely, yes. It's pattern recognition. It helps you make an educated guess about the likely cause and start appropriate treatment quickly.
Okay, here's where it gets really interesting, Len. Paint the picture. What does a typical pneumonia case look like when they walk in the door?
Think sudden and severe. Acute onset, high fever, those shaking chills we mentioned, a productive cough bringing up colored sputum, often that sharp pleural pain.
Sounds rough.
It is. And on exam, the physical signs are usually positive. You hear the crepitations, the bronchial breathing, you find that dullness on percussion.
Yeah.
And the X-ray typically shows that nice, clean lobar consolidation. The classic buds here are bacteria like Streptococcus pneumonia, that's pneumococcus, and Haemophilus influenza.
Okay, clear picture. Now contrast that with atypical pneumonia. How is that different?
It's much more subtle, often gradual. The onset is more subacute, maybe just a low-grade subfebral fever, or none at all.
Not those dramatic chills.
Usually not. The cough is typically non-productive, dry, and hacking. And patients often complain more about non-respiratory symptoms, headache, muscle aches, severe fatigue, sore throat.
More like a bad flu sometimes.
It can seem that way initially.
Mm.
And importantly, the physical signs on chest exam might be minimal or completely absent. The lungs can sound surprisingly clear.
Wow, so the exam might fool you.
It can. And the X-ray often shows more diffuse, patchy, or non-lobar infiltrates, not that dense lobar pattern.
And the bugs causing this?
These are often the atypical bacteria, like Mycoplasma pneumonia, Chlamydophila pneumonia, or even viruses or Legionella.
It's incredible that just based on whether the fever is high with chills versus low grade or the cough is wet versus dry, the whole picture changes.
It really does. That initial typical versus atypical assessment is fundamental because it guides the first choice of antibiotic, even before you have culture results.
Which leads us perfectly into the tailored therapy for CAP. So treatment isn't one size fits all.
Definitely not. For CAP, clinicians divide patients into three main groups based on severity and where they need to be treated.
Okay, what are the groups?
Group 1 is for mild pneumonia, treated as an outpatient in the clinic. Group 2 is for moderate pneumonia requiring admission to a general hospital ward. And Group 3 is for severe, life-threatening pneumonia needing intensive care ICU.
What pushes someone from Group 1 outpatient into Group 2 needing the hospital? What are the deciding factors?
Several things tip the balance. Obvious signs of severity, like low oxygen or confusion, but also risk factors. Having significant comorbidities like heart failure, diabetes, COPD,
Other health problems?
right? Also, a history of antibiotic use within the last 3 months is a big one, or recent use of corticosteroids,
Why is recent antibiotic use such a red flag?
because it dramatically increases the risk that the bacteria causing the pneumonia might be resistant to standard antibiotics, especially pneumococcus being resistant to penicillin. That possibility alone might mean they need hospital observation and stronger drugs.
Got it. So let's look at the treatment for groups I and 2. For group I and the outpatients with mild CKP, what are the usual antibiotic choices?
For generally healthy outpatients in Group I, you've got a few options. You could use a basic penicillin like amoxicillin, or a macrolide antibiotic like azithromycin or clarithromycin.
Macrolides are good for those atypical bugs, right?
Exactly. That's why they're often a good choice for outpatient CAP, where atypicals are common. Sometimes a tetracycline like doxycycline, or potentially a respiratory fluoroquinolone like levofloxacin, though those are often reserved a bit more. Maybe a beta-lactam plus a macrolide combination sometimes too.
Okay. Now, for group 2, they're sick enough to be in the hospital, but not ICU. What's the approach there?
So for Group 2, admitted to the ward, the intensity steps up. A common first choice might be intravenous penicillin G, maybe with a macrolide added alongside it to cover both typical and atypical possibilities.
Covering the bases.
Yes. An alternative could be one of the broad-spectrum respiratory fluoroquinolones, like levofloxacin or moxifloxacin given for P. These cover a lot of ground effectively.
Now, within group 2, in the hospital, there's a really critical decision point regarding a particularly nasty bug. Pseudomonas aeruginosa?
Ah, yes, Pseudomonas. That's a game changer. It's a tough, often resistant bacteria usually seen in sicker patients or those with specific risk factors like structural lung disease or recent hospitalizations.
So if the doctors don't suspect Pseudomonas is involved,
If there's no specific risk of P. aeruginosa, they might use a broader spectrum intravenous antibiotic like a third-generation cephalosporin, say, ceftriaxone, usually combined with a macrolide to keep that atypical coverage. Still strong, but not the absolute top-tier anti-pseudomonal drugs.
but if they do think Pseudomonas is a risk,
Then the antibiotic choice becomes much more targeted and aggressive. You must use drugs with reliable anti-pseudomonal activity.
like what? What are these big guns?
We're talking specific anti-pseudomonal cephalosporins like cefepime or ceftazidime, or an anti-pseudomonal penicillin combination like piperacillin tazobactam, or even a carbapenem like imipenem or meropenem. These are very broad, very powerful. Often these are paired with another anti-pseudomonal agent from a different class like ciprofloxacin or an aminoglycoside.
Wow, okay, so suspecting that one bug drastically changes the medication list?
Absolutely, it requires a specific, potent, and often combination therapy approach.
Finally, once treatment is started, how long does it typically last? Is it just until you feel better?
Not quite. The general rule of thumb is to continue therapy for about 1 week after the fever has completely resolved and the patient is stable.
Okay, a week after the fever breaks.
But the total duration really varies depending on the suspected or confirmed pathogen. For standard pneumococcal pneumonia, maybe 7 to 10 days total.
And for the others?
Atypical infections like Mycoplasma or chlamydia pneumonia often need a bit longer, say 10 to 14 days. Something like Legionella pneumonia requires a longer course, often 14 to 21 days.
2 to 3 weeks for Legionella.
Yes, it's harder to eradicate. And for severe pneumonia, Group 3 in the ICU, treatment duration is generally longer as well, usually at least 2 to 3 weeks, sometimes more, depending on response and complications. What really stands out from all this is how tightly linked the diagnosis and the treatment strategy are.
How so?
Well, think about it. Those initial clues, the symptoms, the physical exam, the x-ray pattern, they lead you to classify the pneumonia, maybe as typical or atypical CEC key.
Right, that first big decision point.
And that classification, combined with assessing the severity and risk factors, directly determines which treatment group the patient falls into, outpatient, hospital ward, or ICU.
And therefore, which antibiotics they start with.
Exactly. Even before the lab confirms the specific bug, that clinical assessment and categorization sets the entire initial therapeutic course. It's about making the best educated guess, fast.
So, what does this all mean for understanding pneumonia? It means those subtle clinical distinctions aren't just academic, they have immediate, real world consequences for treatment.
Absolutely. Recognizing whether someone presents with that sudden onset high fever, chills, productive cough, the typical picture versus the slower low fever, dry cough, maybe more body aches of the atypical picture, that recognition is vital.
It guides everything that follows.
It really does. It helps decide the intensity of care needed and the type of antibiotic coverage required right from the start. And here's something to think about. Given that the initial treatment for CAP is so often based on this clinical pattern recognition, typical versus atypical, plus risk factors before definitive culture results come back.
Which can take days.
Exactly. How much of that critical, potentially life-saving decision-making relies purely on the clinician's ability to accurately interpret those initial signs and symptoms and the X-ray? That framework we've discussed gives you and the doctors a massive head start in navigating the right path forward.